Good afternoon, everyone. Thank you for joining us today. Welcome to our COVID-19 Community Forum. Speaking with us today from Mayo Clinic Health System, Northwest Wisconsin, will be Dr. Richard Helmers, Regional Vice President, Jason Craig, Regional Chair of Administration, Pam White, Chief Nursing Officer, and content experts to help answer myths about the COVID-19 vaccine. You can submit your questions using the Q&A feature at the bottom of your screen. In accordance with Mayo Clinic guidance, it is important to note that each is in their own office, which allows them to not wear a mask. We'll begin hearing information from Dr. Helmers.
Good afternoon, everyone. I'm Dr. Rick Helmers. I'm the Regional Vice President for Mayo Clinic Health System in Northwest Wisconsin. Thank you for joining us today. You are key partners in our Western Wisconsin region. You're leaders from schools and business, law enforcement and local government, nonprofit, faith and service organizations, and community members. And you all have a stake in the impact of this pandemic on our people and in our communities. Our commitment is to be transparent and open about the current COVID-19 situation in our communities. There's no other way to say it. We need your help. We need to have everyone possible to be vaccinated. It is critically important. We are facing a sobering reality in Eau Claire and surrounding communities. We are seeing a surge of COVID positive patients in our hospitals, and the situation is serious. We're sharing this transparently because we need everyone's help to slow down the spread.
Thank you, Dr. Helmers. Next, we will hear from Jason Craig, our Regional Chair of Administration.
Good evening. I'm Jason Craig, Regional Chair of Administration for Mayo Clinic Health System in Northwest Wisconsin. We're grateful for your interest in attending this evening's event. And it's important that in addition to the vaccine information that all of you will receive tonight, that you also come away with an understanding of our currently developing situation. COVID-19 continues to be a major factor in our community. Unfortunately, due to increasing positivity rates and hospitalizations, our modeling indicates that this new surge is imminent. Our current 7-day average daily test positivity rate is over 13%. And just to put that into perspective for all of you, a daily test positivity rate of 5% is what indicates a high level of community spread within our areas. Additionally, we've seen an increase in COVID hospitalizations over the last 3 weeks. And while we're very accustomed to managing hospitals with full hospital beds, COVID patients have much longer stays due to the complexity of their care. And that causes a decrease in our overall availability of hospital beds throughout the region. The reduction in that hospital availability is exactly the phenomena that we want to prevent with higher levels of vaccination. So again, thank you for your interest in attending this evening's event, and we look forward to sharing more information with you tonight.
Thank you, Jason. Next, we will hear from Pam White, our Chief Nursing Officer.
Hello, everyone. As you might imagine, this surge in COVID-19 cases takes a huge physical and emotional toll on our staff. We're only human, and just like you, we're tired of COVID. We wish we were talking about COVID-19 in the past tense, but we're not. We now need the community, you, to hear this important message. If you're not vaccinated, we urge you to take action as soon as possible. We're asking for your help to flatten the curve and the spread of the infection by getting vaccinated, wearing your masks at work and in the community, and avoiding large gatherings, while also washing your hands and keeping space between you and others. We recognize and share your fatigue with all that this pandemic has done to our personal and professional lives, but staying safe and leading by example remains critically important.
Thank you, Pam. It's now my pleasure to introduce all of you to our panel of experts who will be sharing information with all of you tonight. We'll start off with a slide demonstrating all of the experts who are joining us here tonight. So, there we go. So we will start with Dr. Mohamed. Dr. Mohammed is the chair of our infectious diseases division here in Northwest Wisconsin. Maggie Peinovich is our senior manager of pharmacy. Dr. Adela Taylor is a physician in allergy and immunology. Jodi Wickman is one of our nurse administrators here in Northwest Wisconsin. Dr. Blenda Yoon is a physician in obstetrics and gynecology. Dr. Adel Zurob is the medical director of our critical care unit. And then last but not least, Dr. Olawale Onabile is a physician in our hospital internal medicine service here in Northwest Wisconsin. So our panelists are going to kick off their portion of today's program by each addressing one of the more common questions or common concerns that they have received and experienced over the course of the past several months since the vaccine has become available. So we will start with Dr. Mohammed. Dr. Mohammed, the COVID-19 vaccine is not safe because it was rapidly developed and tested.
Thank you, Jason, for the introduction and for the opportunity to speak to the community. As we all know, that COVID-19 pandemic has been expanding rather quickly. Rather urgent measures are needed, to stop this spread of this infection. One of these measures, for all the infection is to consider vaccine. COVID vaccine was one of the measures that started early during the pandemic, and early work has been started, during the early phase of the pandemic. The COVID vaccine itself, if we talk about the part that everyone is concerned about, which is this is a new technology. The first thing is that technology itself is not a new technology. It has been around since 1990. It has been in trials for many infections, and actually has been used to try to treat some of the cancers. And I have a couple of slides that are going to show what has been done. So this slide is actually from 2017, which is about 2 years before the vaccine was developed. And here is showing the leading messenger RNA technology that has been used in different areas, as we see on the right side here of this slide. The next slide also go in further details in telling where the messenger RNA vaccine is being used. And here we're looking at all the clinical trials actively enrolling or has been completed for to treat different kind of cancers. The next slide also is focusing on infections, and we see here that there has been a tremendous work going on for HIV-1 infection and for other infection like Zika virus and rabies virus. And as we see here, Moderna is one of the companies that actually produced the current COVID vaccine, has been working on other vaccines around the same time. So did we skip phases, or steps in creating this vaccine? And the answer is no. All the steps that for creating a new medication or new vaccine has been followed. But if you look at the tremendous effort that has been put in place for making this vaccine, we will see that the hours that place in creating this vaccine and managing any possible side effects is actually exceeding any prior vaccine that has been around. So from that perspective, yes, the vaccine has developed rapidly. However, no steps has been skipped and no safety issues that has been addressed, all this time.
Thank you very much, Dr. Mohammed. Appreciate that insight. Next, we're going to move to Dr. Zura. Dr. Zura, people who are vaccinated still get sick with COVID, so I don't need the vaccine.
None of us would let a 16-year-old teenager get into a car without a seatbelt because they heard about somebody die while they're driving with a seatbelt on, right? So with COVID, when we look at the period between January and June, I don't know if the next slide is available, guys, but thank you. So the New York Times looked at data from 40 states, and they basically looked at the period from about January till June. And you can see there that amongst fully vaccinated people, only 0.1 to 5% ended up hospitalized and only 0.2 to 6% died. What does that mean? It means that about 95 to 99% of patients who end up in the hospital were actually unvaccinated, and about 94 to 99% who died were actually unvaccinated. So there's a clear difference. In the state of Wisconsin, it's about 32 times higher risk if you're unvaccinated for you to get infected, and about 13 or hospitalized, and about 13 times higher risk of you actually being or dying from the COVID illness. If you go to the next slide, this is a visual. On the right-hand side, the orange are not fully vaccinated people who ended up with positive cases. On the left side are vaccinated. The difference is huge. If you go to the next one, hospitalizations, you can also tell a big stark difference between the two. If you go to the next one, and these are deaths, huge difference between people dying who are vaccinated versus unvaccinated. I think the other part that's very important to remember, so this is one reason, protect yourself. That's why you're getting vaccinated. But also we need to protect people around us. The example I'd give you is, think of us all as a big pile of wood. And if you throw a matchstick at that firewood pile, meaning somebody who is infected, you always risk this whole pile going up in flames. The idea of vaccination is to wet this pile of firewood. The more wet it is, the more vaccinated people we have, the less likely we are all going to go up as a community in flames, so to speak. So we vaccinate to protect ourselves, but also to decrease the chance of our community catching a fire like this with COVID. Thank you.
Thank you, Dr. Zura. Appreciate that insight. Next, we are going to go to, in fact, I think we're going to go back to you, Dr. Zura.
Sure.
I already had COVID-19 and I have recovered, so I don't need to get a COVID-19 vaccine.
Yeah, so Dr. Onabuli couldn't be here today, but I'm happy to answer this question. So basically, the state of Kentucky, they had a study there which looked at the at cases of COVID that occurred amongst previously infected patients. So these are reinfections, people who had COVID and then they were reinfected again. Now, some of those were vaccinated, some of those were not vaccinated. And it turns out that your odds of being reinfected with COVID-19 if you are unvaccinated is about 2.5 times more likely than if you had been vaccinated after your infection. So there's plenty of data. There's also data from other states coming out that shows that if you get vaccinated after you've been infected with COVID, the odds of catching it again are smaller, much smaller. There are a lot of studies, a lot of cases that I'm sure you've read about of people who were infected once, they get infected a second time and they're sicker. There's a lot of anecdotal data at this point that a second infection tends to be more severe. We don't have that yet answered, but there's clear value in vaccination after infection.
Very good. Thank you, Dr. Zura. Much appreciated. Maggie Peinovich, more people die as a result of a negative side effect to the COVID-19 vaccine than die from the virus. Go.
Thank you. Thanks so much for having me today. I'm humbled for the opportunity to join this panel of amazing Mayo colleagues. Can you go to the next slide for me? All right, when it comes down to it, the death from COVID-19 vaccine is extremely rare. More than 363 million doses of COVID-19 vaccine have been given in the US as of August 23rd. These vaccines have undergone the most intensive safety monitoring in US history. The tool we use to monitor the safety of vaccines is the Vaccine Adverse Event Reporting System, referred to as VAERS. In VAERS to date, 6,968 deaths have been reported in vaccinated individuals. Now, just because a death is reported in VAERS doesn't mean it was caused by the vaccine. We as healthcare providers are required to report any death that occurs after COVID-19 vaccination. So for example, if a recently vaccinated patient dies in a car accident, that death is reported to VAERS for investigation. Each reported death is investigated through death certificates, autopsies, and medical records, and these have shown no direct link between COVID-19 vaccine and death. Johnson & Johnson has been linked to a rare but serious adverse event called TTS. This is a condition in which a patient develops blood clots with low platelets and has been linked to 3 deaths in vaccinated individuals. So again, very rare. Next slide. Now let's shift gears and look at deaths resulting from COVID-19, the virus. 1 out of every 512 Americans has died from COVID-19. Through August 14th, 614,531 deaths have been attributed to COVID-19. Now, compared to the 3 deaths related to TTS, a negative side effect linked to J&J, the virus clearly causes more death than vaccination. Thanks.
Good. Thank you, Maggie. Appreciate that insight. Jodi Wickman, children don't get COVID and don't get as sick, so they don't need to be vaccinated.
Good evening. Thank you for having me join this panel as well. So since the start of the pandemic, children have had less positive rates of COVID positivity compared to adults. However, since the start of the pandemic, 4.5 million children have tested positive for COVID. So while we are seeing an increase in positivity, especially recently with the Delta variant. So if you look at this slide, you can see that during the last COVID surge, we had a positivity, a highest rate per week at 211,000. And last week alone, 181,000 children tested positive for COVID. The concerning part with this is that we are just on the upward swing of our COVID surge with the Delta variant in the United States. With schools reopening, the concern is what this number may do in the next several weeks. So with the Delta variant twice as contagious for unvaccinated individuals, including our children, they are at greater risk of contracting COVID. So what do we need to do? We need to have children that are eligible for the vaccine, ages 12 to 17, receive vaccination. For those that are under the age of 12, we should have them wear masks, social distance, and wash their hands. So again, children are getting sick. They are getting sicker. And in fact, as of earlier this week, 1,900 children were hospitalized with COVID and the Delta variant. And again, as the Delta variant spreads across the United States, the concern is, what are we going to do and how are we going to care for these hospitalized children? So again, if your child is eligible between ages of 12 and 17, please have them vaccinated.
Thank you, Jodi. Appreciate that information. Dr. Taylor, I am allergic to eggs, so I shouldn't get the COVID-19 vaccine.
Thank you, everyone, for attending this community forum. I am lucky enough to get the easiest question. So the COVID-19 vaccine does not contain any eggs. In fact, if we look at the ingredient list, it has one of the simplest ingredient lists of all. So egg is present in yellow fever and some influenza vaccines, although egg allergic patients are able to receive influenza vaccine, and egg is in rabies vaccines. So the COVID-19 vaccine does not contain egg. It does not contain formaldehyde, glutaraldehyde, does not contain gelatin, bovine or porcine. It is very safe. And initially there was concern about polyethylene glycol. We do screen for that. If you've heard that word before, polyethylene glycol is often used in bowel preps and as a laxative, so it's very common. It's also present in many vaccines that people have received as part of our normal immunization group. So there's been one anaphylactic reaction related to PEG to date. So in closing, the COVID-19 vaccine is one of the, I'll call it cleanest because it has the fewest ingredients than any of our other vaccines out there, contains no egg or other concerning allergens such as formaldehyde and gelatin. Thank you.
Thank you, Dr. Taylor. Dr. Yoon, COVID-19 vaccines cause infertility or miscarriage?
This myth came out early on, and unfortunately has not died out yet. I still get asked this question several times a week, and so in looking at this myth, I like to try to start with where did this myth originate from. So this myth originated from the idea that somehow the antibodies produced against the spike protein to the COVID-19 interfered also with, there is actually a spike protein that helps the placenta attach to the wall of the uterus in pregnancy. That spike protein is called syncytin 1. It is a very different spike protein than the one that's on the COVID, on COVID. And so there actually is no interaction. They're not genetically similar at all. They just happen to be in this very broad category called spike protein. If this were true, there would actually be no difference between women who got vaccinated and women who got COVID naturally. So it's interesting that this myth has perseverated for so long. And it is not what we see. We don't see the medical condition where someone's placenta falls off the wall of the uterus is actually called placental abruption, and we have not seen an increase in those cases. This slide states that all the major organizations, the Professional Society, the American Society for Reproductive Medicine, American College of OBGYN, and the Society for Maternal Fetal Medicine all put out a joint statement supporting that COVID vaccines do not impact fertility. And if you still don't believe that, there is a reproductive endocrinologist who specializes in fertility who did a study that looked at success of in vitro fertilization in women who were vaccinated versus women who were not vaccinated, and saw no difference in those rates of fertility. So lots and lots of evidence to debunk this one. Thanks, Jason.
Good. Thank you, Dr. Yoon, and a huge thank you to all of our panelists for your willingness to address these commonly asked questions. Our guests and attendees tonight have already begun populating the Q&A portion. So at this point, I'm going to hand things back over to Dan Lee, who is going to facilitate the Q&A for the group. So Dan, take it away.
Thank you, Jason. Again, you can submit your questions using the Q&A feature at the bottom of your screen. And we'll start with the first question. What is the research on COVID attacking and feeding on inflammation in the body? Is anyone able to answer that question or know what they're referring to?
So, I'm not quite sure what the question is referring to, but, I'm just assuming that the question is referring that if, one of two options, either if the patient is having a weak immune system, or if the patient is already having an underlying inflammatory conditions and then get infected by the virus. For the first part, if the patient is having a weak immune system, there's always this consideration of the body is fighting the infection. It has been, found that there is a correlation with, weak immune system and, the more infections. So as what happened in the news recently, that there is the FDA approved a third dose for those patients with moderate to severe, immunocompromised status or weak immune status under the emergency use authorization. If the question is referring that the body is already having an inflammation and then the patient gets infected with the virus, then that's probably another so that underlying inflammation probably related to an auto or the body is forming inflammation against the own body. And those are two different categories of issues. The virus will induce further inflammation from different kind of cells. So I'm hoping that that's covered the questions, but I'm not sure if that's all what's meant in the question.
So the question is is not clear, but one thing that we see, how does a virus damage tissue? The virus itself can damage tissue by, multiplying or destroying a cell, but also it can induce an immune reaction that is so severe that it actually damages, we damage our own body too. And one of the things that happen with this virus is it causes an inflammatory reaction that affects many different organs in the body. In the lung, for example, we have a lot of intense inflammation that destroys lung tissue. Some vessels are being, caused to have vasculitis, which can also cause damage to other organs. Many of the medications that we're using actually work by modifying the immune response that the body has so that it's not too excessive and so that our own immune system doesn't even attack us too. So I don't know what the question is really referring to there, but it definitely is a unique feature of this virus that it does cause our immune system to go haywire somehow. And some of our medications try to modify that. I don't know how to answer this question without more information. Thanks.
Thank you, Dr. Zurob and Dr. Mohammed. Next question, why isn't there a vaccine using the actual virus like influenza?
So I can answer this. Oh, go ahead, Dr.
I can take that one. One of the things that Dr. Mohammed was talking about in his myth busting area was talking about that this vaccine was developed more rapidly than traditional vaccines. And one of the reasons that this vaccine has been developed more rapidly than traditional vaccines is because it is an mRNA vaccine. mRNA technology has been available for a really long time. And one of the benefits of mRNA technology is that you can rapidly respond to something like this, whereas developing a traditional vaccine would take a very long time. I think of an mRNA vaccine as sort of like a Post-it pad. So what happens is that it took a long time to develop the paper, the glue, putting it all together, assembling it. That took years and years and years, 20 plus years. But now all we have to do is write something different on the pad. So you just have to figure out what to write on the pad, and you can hand the paper over to your cells to tell it what to make. So that's why we have this vaccine so quickly. That's why this is an mRNA vaccine and not a traditional vaccine, because we needed to quickly respond to this pandemic.
And I think I'll just add to that, Dr. Yoon. I think that's a really great point. When you bring up the flu vaccine and it is based on the virus, we have to start production of that so far in advance. And viruses, they cause variations, or they mutate through the course of the season. So when we have to start creating those vaccines so far in advance, like the flu vaccine, we end up having a vaccine that's 40 to 60% effective in preventing influenza. So the fact that we can make these so rapidly and not base them on the virus that is present at the time is a huge advantage with this technology.
Thank you, Maggie and Dr. Yoon. Next question, why isn't natural immunization considered to be as effective as the vaccine? What is the new info on natural immunization?
So natural immunization, I'm presuming that the person is referring to somebody gets infected, and then why isn't that enough for them to avoid catching this virus again? A lot of things go into it. Viruses change, and it's not really always very clear why your risk is still high if you have had the virus recovered, but compared to somebody who's had it recovered and then gets vaccinated. But we do know from what we're observing that by boosting or stimulating your immune system or revving it up by giving you a vaccine, even if you had been infected before, we seem to produce antibodies, activate, other immune mechanisms, be it T cells, B cells, other mechanisms. And we know from studies that are out there that your risk is much less. So if you are infected once and you don't get vaccinated, you're 2.5 times more likely to get reinfected than somebody who was infected once and got vaccinated. Maybe one day we will discover the nuances of difference between immune result that is from a natural infection that you get versus what we're doing with mRNA or other vaccinations. But where it stands right now, we know there's a difference. At some point, people back in June, I think Cleveland Clinic came out and said, we're not really sure if vaccinating people who are infected works or not. Just so that you know, here recently they came out and said, wait a second, that was old news. This was June, just some employees we looked at. This is before Delta. Scratch all of that. We don't know. Get vaccinated after you get infected. So I think right now the consensus is that if you are infected, you are still prone to getting reinfected. If you get vaccinated, it doesn't mean that you'll never get reinfected, but your odds are better. If you're planning on driving a car, you put on your seatbelt, you check your brakes, you make sure your headlamps work, because maybe your chance of getting in an accident is less and your chance of surviving is better. But nothing is going to be absolutely 100% foolproof. So even if you're infected, getting vaccinated does give you protection.
I want to add one thing here, just quick numbers, So a recent study was published that's showing comparing those patients who or people who was having the vaccine and not having the vaccine. So the risk for getting the infection is 3 times for someone who was not vaccinated. The risk of having symptoms for the infection is 8 times that. And the risk of being hospitalized is actually 25 times if that person is not vaccinated. And the risk of death is also much higher for someone who's vaccinated, who's not vaccinated. And it's actually 0 in someone who is vaccinated, according to the studies that published by the major vaccination company that we have so far. Let alone that, we really, this is being in the process to be studied, the long haul from getting the infection in someone who is vaccinated and from getting side effects from the infection in someone who's vaccinated versus that person who's not vaccinated.
All right, thank you, Dr. Zurob and Dr. Mohammed. The next question I think is very similar. The only addition here is specifically calling out the Delta variant. Are people that had COVID-19 just as immune to getting COVID-19 or the Delta variant than those who received a vaccination? So those who had COVID-19 do not need the vaccination or may need a booster after several months. Do you have any more to add on that?
I don't think there's really much to add in the sense that regardless of which virus you might have caught in the past, whether it's alpha, beta, gamma, delta, you're still at risk of getting reinfected. Getting vaccinated decreases that risk. Nothing is going to eliminate it 100%, but it decreases the risk of a reinfection. So what we know about Delta is how it's different from the previous version, so to speak, of the virus. On the one hand, it tends to be more infectious. So somebody who's carrying the Delta virus is more likely to infect more people around them. But also with viruses, statisticians can calculate how likely a certain virus is to spread in the community, not just infect other people, but actually take off. And one thing about Delta is that it's very different from the ones before it in that it's more likely to spread. It's more likely to set that pile of firewood aflame than the previous ones. So instead of having little outbreaks with the other ones, you have a big outbreak very quickly with Delta. That's why it's different. That's why it's more dangerous. And then the other thing we're seeing is that it seems to be affecting more kids than what we've seen with the previous wave of this pandemic. So there's little doubt that Delta is a little bit more dangerous than the other strains we saw. Is it the last word? I don't know. I have no idea what 6 months from now will bring and what Greek letter it will be. But what we know right now is that our best shot at protecting our community and ourselves is to get vaccinated. Regardless of whether you were infected before or not, get vaccinated. It'll protect you by decreasing your chance of hospitalization, decreasing your chance of death. It'll also protect your family, your neighbor, your community, your children, your neighbor's children, by making it less likely for this virus to spread in our community, overwhelm all of us, our businesses, and our hospitals. That's why we're talking about vaccination.
Yeah, I just want to add one more thing to that. Delta has changed the game. So, the things that we were talking about last year when we were talking about COVID, sometimes people get frustrated because they're like, well, that's not what you said last year, but the game is changing and we've got to change with it. We've got to adjust our strategy. We've got to be more aggressive. We've got to get more people vaccinated. The game has changed.
Thank you. So a question about schools. Why are schools going back in person when the rates are increasing and we're on the verge of a crisis and some schools are not even requiring masks? Do you have any comments about that?
I have a comment, but not an answer, but maybe Jodi, you want to do it? Go ahead.
Sure. So I think that's a great question. And, what we have seen with the Delta variant is, as we've all discussed, is that the contagiousness of this illness is 2 times higher than what we had seen a year ago with other variants. So we know that masks protect us. So that's why over the course of the last 18 months, we have worn masks when we didn't have a vaccine. So we do have a certain part of the population, those ages 12 and older, that now can become vaccinated, but our school-age children under the age of 12 are not eligible for a vaccine yet. So really the best way to protect our children from getting the illness is to wear a mask. And we've seen this at school districts in Florida, that they went back to school without wearing a mask. And now they have a significant increase in the number of cases of children. So I think for all of us, we all live in communities and we have children that go to school. And so it's really being a voice for our children, encouraging all of us to go to our school boards and our administrators requesting and for our children to wear masks to protect them, because we are seeing an increase in hospitalizations and we are seeing an increase in our children getting this Delta variant.
Okay, thank you. So a question about influenza. Why don't we treat influenza the same way?
I think I'll try and answer this one, and Maggie can help me. I think we do treat influenza the same way we are treating COVID in terms of talking about vaccinations. I mean, every year we have influenza vaccines come out to help people prevent them from getting infected with the new strain of influenza. Now, the virus itself is very different. So then the medications that are needed to treat influenza versus COVID also differ. But in thinking of the question in terms of vaccinations, I think we do try and vaccinate people for influenza every year. And now we're encouraging people to vaccinate for COVID to prevent the severe infections.
It's actually interesting because the Pfizer-BioNTech vaccine, one of the reasons that it was able to come out quickly is because they were actually already working on an mRNA influenza vaccine. So that was actually already in the works. And so then when COVID hit, they flipped over to COVID instead of influenza, but that was actually something that was being worked on already.
Yeah, and I think like we talked about, the mRNA vaccines are going to become the gold standard. And differently with influenza, it happens to be seasonal. And so we don't have to give a shot more than every year because influenza comes in the fall and tends to leave us in the spring. If it was around all year, we would be vaccinating more frequently. So we're vaccinating and we're taking the same approach that we do with influenza. But like you mentioned, it's a different virus. So our treatments are different from that respect.
I think I just want to add one thing here. So the best treatment for the influenza is prevention. And the prevention lie within the same measures that we are using now for the COVID, which is, washing your hand, basically staying home when you are sick, and stay hydrated, so it's all of the things and get vaccinated. So there's a big similarity here between the COVID and the influenza. The other thing that, the influenza is a different virus. So, as Dr. Taylor mentioned, the treatment will be different. And also, to start with, the influenza, when it attacks the body or enters the body, they go to a different kind of receptors, different than the COVID vaccines, the COVID infection itself. So that implies that, influenza mainly lower respiratory, lower in the lungs, and the COVID more of a higher in the upper airways. But both of them, they can, affect the both areas. So I think, using the same things that we're using for COVID vaccine, prevention, wash your hands, all of this, can help prevent both the COVID and the influenza.
And Dr. Mohammed, I have just a quick question for you, because we were all masking and being really safe last fall, and you take care of our influenza patients as well, I think, in the hospital. Were we seeing as many cases of influenza? Because what I remember from the fall and the winter was we had almost no hospitalizations from influenza because we were all taking these same sort of preventative measures. Is that true?
Yeah, that's completely true, Maggie. So I think the lower cases of influenza are is the byproduct of following the protection from the COVID infection itself. So I think and I'm very surprised. Usually we see a significant number of influenza patients in the hospital and in ICU. And Dr. Zurob, probably he's experienced that the same thing. But last fall, I think I probably saw only one patient with influenza, but not that's a huge difference.
Thank you. Next question. If someone who had positive COVID several months ago, a fairly severe course, and now has residual long hauler syndrome, does remdesivir have a place in treating these remaining symptoms?
Unfortunately, the answer is no. So remdesivir, first of all, is not approved for that, and that's not how it works. But this is a new phenomenon that we're seeing, and we will see down the road what works and what doesn't work. But based on our knowledge now, we don't know that any of these medications truly work. However, there has been anecdotal data about people who had chronic symptoms, so to speak, from COVID, post-COVID infection, improving, or at least reporting improvement after being vaccinated. Now, I don't know that we know this 100% yet. A lot of it is anecdotal, but it doesn't hurt, I guess, to know that some have reported their symptoms resolving and getting better after they were vaccinated. Maggie, do you have any other information on that part?
I don't really, other than, it's not indicated in that population, unfortunately.
All right, thank you. Question about the mRNA vaccines. What other mRNA vaccines might I have had in life? One slide made it look like other mRNA vaccines exist.
Yeah, since that was my slides, I'm just gonna answer this question. So those are clinical trials. Some of them are already completed. Some of them are in ongoing trials. So as of now, I don't know any human messenger RNA vaccine that's being produced. However, there are so many promising vaccine that I think with having the experience with the COVID, I think this will start being shown. And as Dr. Yoon mentioned, that is actually in the process of having an influenza messenger RNA vaccine, and that's part is in phase 1 trial.
All right, thank you, Dr. Mohammed. Next question, what about the adverse side effects of myocarditis in young adults? Is this something to be concerned about?
I don't know if Jodi had numbers on that, but the incidence of myocarditis after being vaccinated is very small. And the majority of those kids actually have recovered just fine with observation. So if you take the chance of developing that versus the chance of getting sick from the virus itself, from the infection, you are still winning. It's not that you get to choose not to have the infection. Basically, if the choice is between being vaccinated and protected, against severe illness and hospitalization and death by having the vaccine. And then on the other hand, the choice is not being protected and risking getting this virus, which could easily kill you, and we've seen that, then I'd always choose getting the vaccine. The odds of a side effect from the vaccine is very small. And to date, those side effects, when they were potentially linked, like the myocarditis, have been very mild and people recovered with mainly observation. So on balance, it's not like you get to choose that you will never have the infection and you'll never have a side effect. You're picking one of those two. And so on balance, you're a lot better, much likely to win by betting on the vaccine than betting on getting the virus.
And, just to point out all the safety studies, the rigorous safety studies that are being done on these vaccines, the reason why kids 5 to 11 haven't been approved yet is because the FDA doubled the amount of kids that they wanted in this trial because myocarditis is such a rare side effect, but there is a potential that it could be a side effect in people that age. So they actually the companies had to reopen enrollment in their studies and double the number, which is why it's taking longer for that to get approved. I see that question is coming on later on, and it's pertinent to this one too. So
I want to add to that too, because it speaks to our tracking system and the sensitivity of our VAERS system and our reporting system, that we have these rare adverse events and we're picking up on them. So I think I mentioned 363 million doses of vaccine have been given, and we're picking up on tens of cases. So in the 10s, 40s of these adverse events. The fact that we've given that many and we're picking up on those is just a testament to how closely we're watching these vaccines and looking for any sign of an adverse event. And when those blood clots first came from TTS with J&J, that was really scary for us all. And I think it was recalled, but really what we did as a medical community was paused and said, what's going on? How can we address this? How can we move forward and look for this and take care of our patients and move forward in a very safe way? And picked up on those 6 or 7 cases initially out of millions and millions of doses. So that makes me feel really good about giving the vaccine, getting it, is that we are watching it so closely. And we picked up on those myocarditis cases, when in most cases, if we weren't watching those patients closely, we wouldn't have even known they have myocarditis. And they were, we admitted them and watched them overnight, and that resolved.
I would like to also just piggyback off of Dr. Yoon and the children ages 5 to 11. There's a question coming up that when will that approval be available? And so the clinical trials should be completed sometime early September, October, with FDA review at the end of this year. So we're hopeful that the data is supportive of approving that vaccine for ages 5 to 11. We don't anticipate that the vaccine would be available at the earliest till sometime in early 2022.
Okay, thank you. Next question, does the COVID-19 vaccination have a negative result with our immune systems? I see lots of posts that state the vaccine is causing weak immune systems in otherwise healthy people.
I think I could take that one, and that is not true. The idea behind a vaccine is that it presents a protein, or in this case, a piece of a mRNA, which is a code for how to build something. It presents this to our immune system, and then our immune system is able to create the mechanism, the cells, and then from that, the antibodies to fight off this infection. And so the same way that that we're vaccinated with this vaccine applies to all the other vaccines that we give to children and adults throughout their life, and so to protect us from infections. So this does not weaken our immune system. In fact, it adds more what I like to call the antibody soldiers to our immune system as a way to fight off infections.
All right, thank you. Next question, what is the risk of developing Guillain-Barré syndrome from the COVID-19 vaccine?
So the risk, and I have the exact number, so and that's mainly from the Johnson & Johnson vaccine or Janssen. And so from 8 million vaccine given, there was 98 cases. So that's all the numbers that had been studied. And I just want to add one thing, so there are more complications actually from the infection itself. And, and this could include also a weak nervous system or, weak immune system. So while we're looking at the vaccine as a possible cause for this, and from the information that we have so far, all indicating this is unlikely or very minimal possibility for that. We know for sure the infection itself is going to cause all of that and more, and with a significant number. So I think the comparison itself is not justified in this case, because the vaccine is protecting or preventing severe disease and hospitalization, while the virus infection itself is causing the hospitalization and the severe disease.
Thank you, Dr. Mohammed. Next question, why not just use monoclonal antibodies if you get infected over the vaccine?
Yeah, so monoclonal antibodies, I think, are an extremely important part of responding to this virus, and we're lucky to have them. So the idea there is that if you get infected, then we bring you in and give you an infusion that contains antibodies that neutralize this virus, so that hopefully we can abort this infection from getting worse, right? Now, you tell me how any health system will have enough numbers or possibly be able to respond to millions of people being infected. The whole idea is to prevent. It's the same concept as saying, why wear seatbelts, why even have brakes, and why have lights on a car? And we'll just scoop all those millions of people that get in a car crash and bring them to a hospital. Well, good luck having enough hospitals and saving all those lives, right? So the whole idea is, no, we prevent infection. And then the few that are unlucky to get infected, hopefully, we can get things turned around with the monoclonal antibodies. There's no doubt, and I would encourage anybody here on this call, if you test positive for COVID, whether you're vaccinated or unvaccinated, if you test positive for COVID and you are developing symptoms, you should talk to your provider about potentially getting monoclonal antibodies so that we can hopefully avoid you being hospitalized or hopefully avert a death. If you get your test done through Mayo Clinic Health System, there's a team that automatically looks at patients to see if they qualify for monoclonal antibodies, reaches out to them and offers them this. Do you think everybody accepts that? No. So there are still people out there who have been infected, they're obviously getting sick, and they don't want the monoclonal antibodies. I think the key is prevention. The key is prevention. You don't shoot yourself and then say, can you take me to the hospital? Just don't shoot yourself in the first place. So it's very, very important that we don't, catch this virus. Prevent it first. That's what you do. Don't shoot yourself in the foot.
Just want to add one thing here. I think the point that Dr. Zurob made is very clear about the monoclonal antibodies. The one thing that I want to add is the monoclonal antibodies, they don't work on all the viruses, all the variants of the COVID vaccine. So since this became available, actually we lost one of the monoclonal antibodies because it does not work on Delta variant. And the other factor is we need to get the monoclonal antibodies every 3 months. So getting a vaccine once a year, maybe maximum twice a year, if you are have a weak immune system versus getting a medication in a hospital or clinic every 3 months. I think the math speaks to itself.
All right, thank you. Next question, perhaps Dr. Yoon, is for you. Is there a difference in risk of vaccination effects later in pregnancy, such as the 3rd trimester?
The COVID vaccine actually has been shown to be safe in every trimester. So there isn't a trimester that you shouldn't get it in. It is safe in the first trimester, safe in every trimester. One thing is that they are finding that one benefit to getting the COVID vaccine while you're pregnant is that you do actually transfer those antibodies to your baby. And babies actually don't make any of their own antibodies for the first 30 days of life. So if babies get sick during that time, they can get very, very sick. And obviously, it's difficult to tell your friends and family members that they can't see your baby. So, there may be a benefit to getting it in the third trimester, that maybe those antibody levels would be higher for your baby. But at the same time, then if you got COVID in the second trimester and developed severe disease and had to be delivered early and never made it to the third trimester, then that would be devastating as well. So I do encourage every pregnant woman not to delay getting the vaccine, to get it as soon as possible. I don't actually consider that there's a perfect time to get it in pregnancy, because again, Delta is changing the game. We're seeing more and more positive cases every day, and definitely in parts of the country like Florida, Alabama, Mississippi, there is a crisis happening, and we don't want that crisis here.
Thank you, Dr. Yoon. Our next questioner would like to know if you would recommend any of the 3 vaccines as safest.
I think it actually depends on who you are, which vaccine you would consider to be safest. So, again, with the J&J vaccine, Maggie mentioned the TTS, sorry, and one extra TTS, and that has been shown to be more common in young women. So maybe if you're a young woman, you might want to opt for an mRNA vaccine. The myocarditis that Dr. Zurob was talking about is more common in young men. So, maybe if you're a young man, you might want to consider the J&J instead. So it depends a little bit on who you are.
Yeah, I think from the start, we've been saying that the vaccine is the one that you can get in your arm and get vaccinated with. So we don't have a preference, I would say, as a healthcare team or system, other than based on what Dr. Yoon was talking about, where we discuss those risks. But like Dr. Zurob said, those risks are really outweighed by the benefits of the vaccine. And so whatever we can get into an arm, whatever you as a patient have access to and can get for a vaccine, we consider the safest vaccine for you.
Thank you.
I think one of the lucky things about living here is that we do have access to all those vaccines. So I have family that lives in other parts of the world. Some of them are still waiting on the first or any vaccine to be available to them, right? So I think we're fortunate to have these vaccines available. We're fortunate that we can just walk into a Walgreens or a Walmart or a Sam's Club and say, give me my vaccine, please. And there it is, it's available. And I think it would be a shame if we get sick because we decided not to follow, hopefully, advice from trusted sources that take care of you for every other illness, right? And now they're telling you get vaccinated, but this is the one time you choose not to listen to them, and now you end up in the hospital. So hopefully we can help people today believe that this is a safe vaccine and they go out and get vaccinated, because that is going to help them, but help everybody else in the community too.
All right, we've reached about an hour, but our panelists have agreed to keep answering questions for a bit longer because we have many that have come in. The next questioner says, it seems that the medical community is telling all of us to get the vaccine as a one-size-fits-all diagnosis. No matter what our situation, we're being told to get vaccinated without question. This approach has never been used before with any virus. Why this virus?
Yeah, so, it's been used before, but, the response was quite different. If you look at the Spanish flu and if you look at, the polio, actually people are, standing in lines waiting for the vaccine to be given. And they were so thankful, that for having this, medical miracle, to help them, bypass this infection. Currently, things are a little bit different, so there are a lot of resistance, to getting the vaccine and to getting prevention from the infection. I just want to remind you, the polio virus has, basically eliminated, but we're still giving vaccine because we know that, if the polio come back, that will be a major issue. We are moving forward, for, improving, we're having this pandemic coming up, and, the humanity is looking for solutions, and the solution is on our hands now. And I think we should just, have the same reflect, that, our prior generations, had for vaccines in general.
Thank you. Next question. Mayo has locations around the country. What trends in hospitalization and infection do you expect based on what other Mayo Clinic locations are seeing? How does the Chippewa Valley in Northwest Wisconsin compare?
I could answer that. So that we, for the last 15 months, on a daily basis, get information about COVID infections at the other Mayo Clinic campuses. And also we get the predictions from the experts at Mayo about what they think the trends are going to be. So that there, as has been said, there has been a serious number of infections throughout Florida, but the Jacksonville campus has and continues to see a serious number of infections. The number of infections are also rising in the Arizona campus. So the Arizona campus and the Florida campus have seen more patients to date than we have in the Midwest. The predictions show that we are going to continue to see an increasing number of inpatients in Western Wisconsin and in the Minnesota sites, so that the predictions show that we will continue to see a climbing number of patients here. And that is why we are doing events like this, because the only way that we can keep this from happening is for people to get vaccinated.
Dr. Helmers, how does our vaccination rate compare to Florida and Arizona right now?
So the community vaccination rate in this area of Wisconsin is very similar to the vaccination rate in Florida and in northern Florida where the Jacksonville campus is, and also very similar to Arizona. So that's why we're concerned about the predictions that we're going to have a significant increase in number of cases here, because the background community vaccination rate in Western Wisconsin is similar to Arizona and Florida, where they're seeing this happening.
All right, thank you, Dr. Helmers. Next questioner says, I work in a school. What's the best way to avoid being quarantined? Mask, vaccine, both? What's the winning combination?
So the winning combination is both. So even for children that are able to be vaccinated, they should still wear a mask, because we know that the Delta variant is very contagious. And we have seen that even individuals who are vaccinated can have breakthrough cases. For those that are unable to get vaccinated, the number one prevention is going to be wearing a mask with social distancing and washing your hands.
Thank you.
Just want to add what the third part of this equation is testing. So if you or one of the kids at the school having some symptoms, they need to be tested, and things to be detected as soon as possible. So vaccination, mask, and testing.
All right, thank you, Dr. Mohammed and Jodi. Next question, are all babies born by vaccinated mothers born with antibodies regardless of when they received the COVID vaccine in their pregnancy, or does their antibody level in the baby depend specifically on when mom received it?
The babies born to vaccinated moms are born with antibodies, but it is true that that moms who receive the vaccine in the third trimester, the babies do have higher levels of antibodies than to women who received it earlier in pregnancy. It is a little bit that I guess having the presence of antibodies is beneficial, but it's true that it's not quite as beneficial as if they had received the vaccine themselves, because it is a passive antibody transmission, sort of like what Dr. Zurob was saying about monoclonal antibody therapy versus activating your own immune system.
Thank you, Dr. Yoon. Next question, is there any data about the rate of achieving herd immunity through infection versus vaccination? Is it even realistic to think of achieving herd immunity without vaccination?
Well, so before Delta, people thought maybe if we got to 70%, give or take, we will have herd immunity. But when looking at other countries that actually achieved even higher rates than 70%, Israel is one example, they still had a wave with Delta. So I don't know that we know the answer to what it will take as far as total vaccination to have herd immunity, in the sense that you can just walk around and not worry about it. What we do know is we are asking people to get vaccinated because we will decrease the risk of hospitalization or death, and hopefully decrease the risk of that pile of wood catching on fire, where we can get all overwhelmed because so many of us get infected at the same time. Interestingly, earlier somebody asked about, well, other states and what do you see? You know, it's very simple. You can go to any website now and look at which states are currently going through this huge wave and are being overwhelmed, and their hospitals are running out of beds. You know, Louisiana, Mississippi, Missouri, Florida. What do you think they have in common? Low vaccination rates, right? So the evidence is out there. Now, we can choose to ignore it. We can choose not to believe it, but that doesn't change it. A fact is a fact. If we get vaccinated, we're less likely as a community to suffer with this. Are we going to eliminate every infection? No. So if somebody is looking for, but it will happen, of course it will happen. Some people will get infected. Some people will die, even though they were vaccinated. But when we're talking about our community overall, our odds of surviving this individually and also as a group, if you're talking about a herd, as a herd, this herd will survive a lot better if more are vaccinated. It's not because we are going to stop infections, but it's because we're going to fare better when we do get infected. And I think that's really the message. You know, get vaccinated. It's better for you as far as outcomes and odds, better for the community. And maybe one day we'll learn what is that magic number that everybody has to be vaccinated at for us to have enough herd immunity not to worry about it. We don't know that right now. Right now with Delta, that number is not 70 and it's not 60%. It's nowhere near where we're at.
Yeah, so I just want to add to Dr. Zurob, so the number actually, for Delta, someone from the public health, community has calculated that it is about 84%. So if you look at now what the rate of the infection in the United States is 20%. And if you look at the deaths so far, the number of deaths, as of today, and actually as of now is 634,000 and more, and just from 20% infection. So if we want to get the herd immunity of 84 or 85%, we are going to expect a lot of death, and that's a high price to pay. The vaccination itself, if we are able to reach a very high number, which I think, at this time might not be possible. We are raising the variance. So if we are, even if we are able to go over the Delta, was like close to that, we don't know if this not happening rather quickly, we're going to lose to a new variance. So it's really hard or realistically to get to that herd immunity. But I think, if the question is pandemic will end, yes, the pandemic will end. How that's the thing that we want everyone to be participating in.
All right, we'll wrap up with two questions here and then have some closing comments here. Will we need a flu vaccination if we had COVID vaccine, especially since masks helped last year?
I think that's a simple answer. Yes, there are different viruses. One vaccine is not against the other. So the COVID vaccine is against COVID. The flu vaccine is against flu. You can get both or either. When you come to an emergency room, it's now pretty much routine in most hospitals to test you for COVID, flu, and RSV. These are respiratory illnesses or viruses that are common. And yes, I plan to get my flu vaccine when it becomes available. I plan to get my booster when it becomes available. I will make sure that my family gets those, and that includes my 20-year-old sons, who I'm happy that they are safe getting the vaccine, and my 84-year-old father, who I'm happy will be safe getting these vaccines. I wouldn't be sacrificing them just so that I'm here saying, please get a vaccine. All of us will be safer getting vaccinated. And I hope that this is the message that you're getting from all of us. We're not here because we're gained from people being vaccinated. It's something that helps you, helps us, helps the community. And I hope that you do trust your providers who are telling you get vaccinated.
And
I agree 100%. The only question is, to add to that, what's the guarantee that people will use mask all the time? Even if you are using the mask, how about other people? So that's part of the equation. I highly encourage everyone to get the influenza vaccine, just to continue doing that.
Thank you. Final question, are there any local opportunities to enroll kids under 12 in vaccine trials?
No, there are currently no local opportunities. The clinical trials are currently underway and are being completed within the next several months, and there's nothing local at this time.
I think most of us have tried to get our kids signed up for the trials, and there's waiting lists and no possibility to get our kids in the trials right now.
All right, thank you. And that's all the time we have for questions. Thank you all on our panel for answering our questions. We're nearing the end of our time together. Dr. Helmers, would you be willing to offer a few closing comments?
Yes, thank you. We want to thank all of you for attending, and we want to thank all of you for your questions. And we want to thank our expert panel for doing a great job with this. It really is quite simple. If you've not been vaccinated, please do so immediately. It truly makes a significant difference. We're grateful to all of you who are doing your part. Please continue to be vigilant with getting vaccinated, wearing masks, avoiding large gatherings, wash your hands, keeping space between you and others. We know that all of that works. We couldn't be prouder of our staff, or we couldn't be more honored to provide care in our local communities. Each day that passes brings us one day closer to the end of this pandemic. Thank you for helping to lead by example in the community and encouraging everyone in your network to do the same.
Thank you, Dr. Helmers, and thank you for joining us tonight.